thanks everybody. As part of the prepared presentation here today, as was mentioned, the conversation topic at hand is delivering value to an MSO. Specifically, what I thought might be interesting and instructive to the group is just to share perspectives based off of our dialogue nationally and our transactions across the country. How different MSOs have delivered value to the healthcare system by, number one, creating differentiated strategic value to the different constituencies that they have to be mindful of. And then number two, and perhaps even more importantly, building an economic model that positions them for long-term success. It's one thing to deliver differentiated value. It's another thing to do it and also build yourself in a way that you're positioned for long-term success and are economically viable. So with that, I don't know how I do. Oops. I'll flip to, sorry. I'll try to just do it manually then. Okay. Try it this way. So, as a foundational comment, what are the constituencies that an MSO needs to deliver value to? There are three primary constituencies, as perhaps an obvious point: the healthcare payer, the source of revenue for an MSO; the physicians, the network that the MSO is going to be relying upon to service the members of the healthcare payer; and then patients, obviously the members or the beneficiaries of the healthcare payer that the MSO is serving. So how does an MSO deliver differentiated value to each one of those constituencies? That's where I'm going to spend some time on the next several pages covering. So as you think about the healthcare payer, some of the challenges that they're facing and why an MSO can add value to them and to their businesses as a whole is a lot of them, particularly in an environment where the payer landscape is consolidated very significantly, or in the case of state and federal governments where you just have these programs that are just very large and designed for a one-size-fit-all type of approach. They need help figuring out how to develop local market provider networks that suit their patient needs. They need to figure out ways in which they can engage with providers, engage with patients, such that they can help compel behavior change or compel management of those members in a way that is low cost, high quality. They need help in implementing advanced value-based care models. I think value-based care is a buzzword that's used quite a bit these days, with a lot of rhetoric in and around the majority of payments being transitioned to value-based care models. But if you think about the number of payments or percentage of payments that actually have downside attached to them, that's only 10% of overall healthcare spending. And so there's a huge opportunity for much more of that to be transitioned to some of these advanced models, which MSOs are uniquely suited to help with. Implementing quality programs, which is very, very important, particularly with Medicare. Managing high acuity populations. If you think about the 80-20 rule or 90-10 rule as it relates to healthcare spending and where all the high cost tends to be, it tends to be with the high acuity populations. And again, managed care companies and healthcare payers, by virtue of the fact of their size, tend to have difficulties managing high acuity populations at a localized level and controlling costs and optimizing quality. And then compliance. Compliance is of paramount importance, and I'll talk a little bit about that as we think about lessons learned from some MSOs around the country. So how can an MSO create differentiated value relative to those objectives? It's one thing to be able to address them on a headline basis, is another to be able to go to a payer and say, hey, I'm delivering differentiated value relative to some of my competitors who are saying I can do the same thing. Number one, geographic coverage. Do you have a network that is unique relative to another MSO, relative to relative to where your footprint is? Can you adapt to different health benefit designs or different product types, population types? Are you able to service the regular way Medicare Advantage member, the D-SNP member, the C-SNP member, the high acuity Medicaid member, the commercial member? There's a lot of different ways in which you can think about tailoring an MSO to address payer needs, just given how much different types of spending are out there. And then again, the compliance culture. How are you helping them in an environment where there's just more and more scrutiny around compliance? Next category, next constituency is the physician. It's impossible for an MSO, again, is perhaps an obvious point, to service a payer if you don't have a provider network that will take adequate care of the members that's enrolled with that particular payer. What are physicians thinking about as they decide whether to use an MSO, one MSO versus another, or go it alone. Administrative burdens of revenue quality and compliance initiatives. If you as an MSO can deliver differentiated value in terms of helping ease that burden for a physician so that they can focus more of their time taking care of patients or just having more free time, that's a very significant value. Expertise negotiating value-based contract. One of the most significant ways in which an MSO can add value to a provider is by handling all of the negotiations of the payer contract, not letting them have to deal with figuring out what the right rate should be relative to the patient panel that they're taking care of. Support and resources to help with the management of high acuity populations, and then economic opportunity. I mean, I think when it comes down to all of this, it's really about showing the physician that with the MSO, not only is their life going to be easier, but they have an expanded economic and opportunity by virtue of the fact that they can take care of more patients, take care of sicker patients, and again, capitalize on more of the healthcare dollars that are out there. Differentiators for an MSO when they're thinking about how to appeal to a provider relative to some of the other competitors out there or relative to a physician's standalone options is the ability to interface and provide some of those services in a physician-friendly way. It sounds kind of silly when I say it out loud, but you'd be amazed with, and I'm sure some of you have all seen this in your travels, is that there are a lot of groups that have these great, slick technological interfaces, very slick protocols, but when it comes down to it and their ability to actually deliver to a physician in a usable way, something gets lost in translation. So there is a lot of value in thinking about the look and feel in a tailored way, even if you don't have the slickest of capabilities. Reporting analytics capabilities, being able to give them actionable information that means something, the level of support, the types of support you're able to provide them, providing negotiating leverage to payers. So if your MSO has a particularly significant amount of negotiating leverage or density in a particular market or the particular population, that can provide leverage to increase the economic opportunity. And then compensation. This is, again, something that all physicians are kind of keyed in on. And then patients. The other thing that sometimes gets lost, again, we see this across the country, is the need to make sure that the services that are being provided not only cater to the payer, not only cater to the physicians, but that members are happier as a result of the MSO services and support being provided to both the payer and the physician. So what does that mean? Providing convenient access to care, including primary and preventative services, absolutely need to make sure that the network is of high quality and provides adequate amount of access, high quality care at an affordable price, that goes without saying. And again, in terms of differentiators, what does that mean in terms of being able to provide a differentiated level of service, the breadth and depth of the network, the level of clinical support that's being provided to the physicians, to the member to just help them live healthier and better lives, and then supplementary services, a lot of talk in and around social determinants of health, but it goes beyond that. Are there just basic wellness services, basic, just basic services that just, again, help with the wellness, overall wellness and health of a patient population? So with that in mind, as it relates to some of the differentiators with the constituencies, the next topic that always comes up is business model, one of business model. Should we think about an arm's length relationship with the providers that we're helping accomplish all of these objectives to, or should we consider vertical integration? And vertical integration can mean an affiliated model where you have an IPA that contracts out with different physicians. It could mean that you employ physicians directly. It could mean that you have clinics. But the common question is, again, where should we fall within that spectrum? The filter that we've seen be most effective is that if your MSO has some sort of differentiated technology that is a sustainable advantage in the sense that there's a unique set of IP around the interface, around the analytics, around the reporting, there is a very strong case in and around thinking about the third-party model and thinking about the fact that you are providing such a differentiated level of capability and service such that a third-party physician is going to say, gosh, you are very different than all of the other MSOs out there that are pitching services to me. If an MSO can't meet that test, the longer-term existential risk that they're going to face is, how do they preserve that book of business relative to some of the competitors that are coming at them with lower prices and with a very similar set of services? And that's where the advantage comes in of having an affiliated type of model or an employed model where you are vertically integrating either virtually or through employed physicians, them into your MSO such that you have a captive base of providers with which your services are being provided. You also have the added benefit of being able to benefit from a fuller amount of the economic benefits that you're facilitating as an MSO. When you're doing it as a third party, you're typically charging a percentage of premium, and that's the extent of your benefit. If you're doing it as a vertically integrated model, you have the benefit of actually making that percentage of revenue plus the margin in and around the costs that you're saving. And then lastly, and I'm happy to open up for questions after this, is what have we learned based off of transactions and dialogue across the country in terms of success and failure? So on success, we spent some time here just talking about what are some of the reasons why MSOs succeed versus another and create differentiation versus another. Again, to recap, it's about being able to provide a differentiated technology platform, being able to forge strong physician relationships and provide them with a level of engagement that's viewed as cooperative and not adversarial in terms of improving the way in which they manage patients, engage with patients. Being able to manage these high-risk populations that account for a disproportionate amount of cost and a disproportionate amount of the quality problems that some of the payers have. Data that you can demonstrate differentiated quality and margins for payers relative to some of these metrics, and then geographic density, being able to build geographic density that provides a payer with a differentiated network, provides patients with differentiated network, and physicians with more negotiating leverage with the payers. Why do some MSOs fail? What are some of the reasons in which some of them fail to deliver the value to the healthcare system or don't build durable, successful business models? Number one, they just create a really basic arbitrage business model. They feel like just building the network is just enough, and they're just very comfortable in just making an arb between what the payer is paying them and what they're paying out to physicians. That, as an obvious point, probably can't last forever, and it doesn't last forever. Poor clinical capabilities sort of goes hand in hand with my first point. Do you have the set of capabilities to manage the population that you're taking responsibility for? Absolutely critical, otherwise your economics will go upside down. Lack of actuarial rigor on capitation. Something that we're seeing in a lot of places around the market is that everybody says, hey, I want to go and help enable global capitation, but not entirely comfortable without necessarily having full competence in terms of, one, what is the risk associated with the population that they're taking on responsibility for? And then two, not necessarily structuring contracts to provide them with protection to the extent that their assessment on the data is wrong. And that can turn your economics upside down very, very quickly. Weak compliance practices. This is something that's actually happening in California as we speak, where there are a number of MSOs that have gotten into really significant trouble as a result of just not paying attention to compliance as their organizations have grown. In fact, one very, very large one that was managing 1 million lives went to basically 0 lives in a matter of 3 months as a result of compliance failures. And then lastly, inflexible interface with payers. The key thing that all payers want in this environment is a level of flexibility to tailor the solution to the membership that they have. They are also in the process of facing a question as to what they want to be, what sort of capabilities that they need to have that differentiates them from one another. And sometimes they have different perspectives on that. Sometimes they want to keep the analytics in-house. Sometimes they want to keep a certain degree of care management in-house. And being able to tailor the solution to enable providers to work collaboratively with those payers is a pretty important point that sometimes again, can create issues if there's a degree of inflexibility. So with that, that concludes the prepared remarks. Happy to take any questions.
In your experience, in terms of drivers of success, for the practices before they entered into an MSO relationship, how effective in terms of practice management or practice transformation were they? And did the MSO offer an opportunity to improve the operations such that they were ready to play in this market?
The answer I'll give you is it depends. In instances where where physicians have gone into the relationship with an open mind as it relates to the fact that there are things they can improve, there are plenty of case studies of it driving transformative improvement in terms of efficiency, both from an operational side and a clinical side. There are examples where where there isn't that degree of receptivity and the relationship fails because they're just not willing to embrace the solutions that the MSO is willing to give them. It's kind of, again, very similar to my business as investment bank. We're all, very proud of what we do, and some of us like to take criticism better than others, and it's kind of a very similar dynamic. Anybody else? All right, well, thank you.